Welcome everyone to another edition of Pulp Nonfiction. Today I have with me a good friend of mine from Calgary, Dr. Tom Shackleton. Tom, you are a general dentist extraordinaire. You went back and got your Diplomate of the American Board of Orofacial Pain. You're also a fellow of the American Academy of Orofacial Pain, and you are working on your fellowship at the American Academy of Oral Medicine. Wow, wow, wow.
I guess I need a hobby.
You have trouble sleeping at night, so those textbooks are just beautiful.
That's right, yes.
Who cannot see enough of slides of red and white lesions of the mouth, right?
Well, I think, yeah, with a little tinge of purple, I mean, it's perfect.
Yes, yes. Well, you know what? As an endodontist, pain is a big topic for me. And I know it is for general dentists, and I know as an endodontist, I'm forever doing pulp testing, and I think I'm not alone in saying this. Once you get a few millimeters beyond the apex, and someone has pain, I start to get a little less comfortable.
Mm-hmm.
And we have some oral medicines and oral pain specialists here in Vancouver. But it is something that I think all of us could benefit knowing more about, and I congratulate you for diving into that deep pool. Yeah. Can you speak a little bit towards your experience?
So,
yeah.
I'm a general dentist. I have an interest in a few different things. I discovered over the years that I would see people who were having pain, like a lot of us. And I couldn't diagnose it. I didn't know what it was. I would see something that mystified me. And so, like I think a lot of dentists, I was part of the problem. I definitely was, where I would just send them out the door somewhere. Go see an oral surgeon, go see a periodontist, go see an endodontist, go see your family physician, go see somebody other than me, because I don't know what to do for you. I know what it isn't. I would go through endodontic testing and poke around a little bit, but I didn't really know how to manage pain. So an opportunity presented itself to go back to school in a hybrid program at the University of Southern California and work on a master's degree in orofacial pain and oral medicine, which I did in 2012. That's when I started, and I finished in 2015. So I worked about 3 to 4 days per week, and then I'd spend a few days per week and most evenings working on projects, reports, assignments. We would have weekly meetings. I would have to travel down to USC frequently to see their patients in their clinics. I finished in 2015. Part of that process in the US as opposed to Canada, there's the American Academy of Orofacial Pain and then the American Academy of Oral Medicine. At the time, neither of them were recognized specialties in the US. They both are now separate specialties. And I pursued becoming a diplomate in the American Board of Orofacial Pain and becoming a fellow of the American Academy of Orofacial Pain. To do that, you have to attend a certified program, and then you have to pass a written exam and then an oral exam. And that was a very difficult, harrowing experience. The oral exam is sitting in a room with 2 other people. I'm sure for becoming a fellow of the Royal Academy, it was a similar process for you. And the day I did it, I had a horrible head cold. And so this was several years ago, but quite literally snot was running out of my face. There was no Kleenex in the room. Nobody was allowed to leave the room because the exam had started. So I sat there for an hour and just worked through cases with them. And the exam would start by one of the examiners saying, "I'm a 65-year-old man with pain on the right side of my face." And then it was up to me to solve his problem. I would have to ask a lot of questions. And I bring that up because, not because of the snot, that's just a cute side anecdote. But a lot of the people we see are just
that. You could have cleared that room if it was this year. Boom, exam over.
This guy fails, never let him back.
Yeah.
Fortunately, no hands were shook that day, that's for sure. So, but a lot of our patients do come in. There's a 65-year-old man, and he says, "I have pain on the right side of my face." Mm-hmm. And so it's up to us to try to figure out what's happening.
Yeah.
And so, as we get into orofacial pain training, a lot of what we're taught to do is how to interview somebody. So we want to find out things like, when did the pain start? How long has this been going on? What precipitated it? Did you have a filling? Did you have an accident? Did you get hit with a baseball bat? Did you get punched in the face? Was the airbag blow up? You have some disease? What's going on? And we can learn a lot just from getting a patient history. And so anyway, the more I learned, the more I love trying to solve people's pains.
Mm-hmm. Yeah, I know it's with the tools, the problem is interesting. Without the tools, problem's a nightmare sometimes, eh?
Absolutely terrifying.
Yeah.
I talk to a lot of colleagues. So I spend probably half of my practice is dealing with orofacial pain patients.
Mm-hmm.
A good part of my practice is also seeing oral medicine patients. There's a bit of a difference between the two. Oral medicine patients tend to be more pathology oriented. It could be infectious. It could be, we see a lot of infections, candidiasis, herpes, things like that. It could be an autoimmune issue. Sometimes it's painful. We see some burning mouth, which we also as a crossover into my orofacial pain practice. Someone may have an unusual lump or bump, so we spend a lot of our time biopsying suspicious lesions. So a lot of back and forth between those two disciplines. I'm fortunate that I practice in a city where there aren't many people who do what I do. Oral surgeons certainly have a similar training, but I don't think it's quite the same as what we do because they're surgeons. And I think as dentists, many of us have a doctor of dental surgery and we have a surgeon's mentality. And it took me a long time to recognize managing orofacial pain and oral medicine conditions requires abandoning that surgeon's mentality. About a year and a half into my program, I was complaining to my program director. His name was Dr. Glenn Clark. Love him, great guy. He's a very straight shooter and he doesn't suffer fools. And I was complaining about, in orofacial pain, nothing's really, it's not a cookbook. When we see somebody, if they have a pulpitis, they have an abscess, we can extract the tooth, we can treat it endodontically. Of course, we can leave it do nothing, but that doesn't seem to keep our practice doors open. So there's a thing we can do. And so we see it, we cut it, we fix it. And that's great. And that's excellent. I think that's a wonderful service to provide. But when we see people who come in with pain, anyway, I was complaining and he said, Tom, you've got to start thinking more like a physician. Stop thinking like a dentist all the time. Start thinking like a physician. Many of these people you're not going to cure. You're not going to cut something and fix it and it's done. So you're going to have to manage these cases, which is why we use that word a lot. We manage people's pain. If somebody has TMD or they have a neuropathy or anything, we're not really curing it. It's like the example we like to use is if somebody has diabetes, we're not curing their diabetes, we're not curing their hypertension. We're managing it. We have lots of strategies to do that. Diet, exercise, medication, all of these strategies are in place to help manage it, but we're not curing them of these conditions. So many people who have joint pathologies or muscle problems or nerve pathologies or autoimmune dysfunction, we're not curing these things. We're managing it. And it does take, for my brain, it takes a very different mindset. I've really had to dichotomize my thinking, from the dentist side of it, where I think like a surgeon. I see something, I fix it. And as opposed to the oral medicine or facial pain side of it, I manage it. It takes a little more patience. And quite frankly, even in my schedule, I'm better now of commingling the two. But for many years, I would say if we're seeing a bunch of orofacial pain patients or medicine patients, just book them in the morning.
Mm-hmm.
Don't throw them in with our dental patients because my brain was having to go back and forth, and my brain anyway. I really struggled with having to try to pull out of that dentist mindset and then slow down and start figuring out what's happening with somebody's jaw pain.
And I imagine part of it too is also training the patients because they're used to coming into a dental office and let's get that drill going and you're done. And because I've come across that, I've had patients, but yes, we're in the COVID pandemic, and I've had patients coming in and like, I've got a toothache, I've got a toothache, I've got a toothache. And, we're dressed up like it's asbestos removal men in our spacesuits. And the lady or gentleman comes in and they have a sensitive tooth because they're clenching and grinding and they're stressed and scared and they don't want this tooth to blow up. And, the natural knee-jerk reaction to the dentist is, oh, you're a bit of a complainer and over complaining, and you brought me in and wasted my time. And it's like, well, actually, no, the pain they're experiencing is true. Let's be focused and empathetic and get this person to around and not sort of make them feel bad for wasting their time. They would genuinely, they thought they turned to us. But I do see that because the natural inclination before the pandemic too was I'd send them off to oral medicine, especially to be a bit disappointed because they're still in the field of dentistry and they're like, well, they got me these medications and they didn't work. I'm like, yeah, but it's like a cocktail. You gotta customize. You gotta go back. You gotta get like more the medicine part of it. And until you've said it now, I didn't think of it as medicine. But that's completely the way. I think we need to train the patients well because they're used to seeing us, minute loop guys. Like we got it fixed. Out you go. And it's more like a BMW Mercedes. It's like, no, you got to keep going back and fixing it, and spending money.
That's right. And a big part of what I do, and actually bring up a couple of great points. There was a great study that came out of the UK probably about 4 or 5 years ago. I can't remember the author, but it was a questionnaire actually, and it was a bunch of patients who went to an orofacial pain oral medicine practice, and just about their experience before and after, and what did they find that they valued. And there's a few things that kept coming up again and again and again. And one of the things that was on the top of the list repeatedly was they listened to me. They believed me. And I've been to so many people and they said, it's all in your head. Of course, the theory is it is all in your head. But because, so many people just weren't believing them because objectively, you look at these folks, you take an x-ray, you do all the tests, everything's pretty normal.
Yes.
We don't see an abscess. There's no swelling in the gums. Like there's nothing we can go, there's no really gold standard test to figure out what a lot of these conditions are. So just listening to somebody, just sitting there and listening, just look at them in the eye and listen. That's very therapeutic for a lot of people, and believing them and then addressing their problem. And that was another thing that came out. They listened to me, they heard me, and then they gave me solutions that helped me out.
Yes.
And a lot of these patients, yes, we have to find out what's going to work. I mean, we have certain protocols we'll use for certain conditions, but it doesn't work for everybody. So for some people, for instance, if they come in with a burning mouth disorder, my mouth has been burning, it's driving me crazy. So everybody, we're going to do a swab for candidiasis. And why do we do that? Well, some people will have candidiasis. They don't look like they have candidiasis. Their tissues look pretty good. So we'll swab around and we send it off. And every now and again, not often, but every now and again, they'll come back positive. We give them nystatin and we call them in 2 weeks and they say, my burning's gone. Wonderful. But we have to review their medications because many cases of burning mouth disorder are medication related. But let's say it's not. Let's say it's a primary condition where there's nothing we can identify as, that's the problem. So we give them, we tell them to take alpha lipoic acid, we have them take a zinc supplement, and we have them take clonazepam. Mm-hmm. They crush it up and they rinse that for 3 minutes, 1 to 3 times per day. For many people, that actually manages the burning condition pretty nicely, but not for everybody. Sometimes we do have to start mixing in medications like gabapentin and or amitriptyline or nortriptyline or things like that. So it is a lot of, like you say, there's sort of some massaging that has to go on. And we really have to find out what works for the individual person. So
now, I'm going to ask you something specific. I had a patient, I worked in Eastern BC, and she was a lovely lady, but she was focused on her oral condition and just could not stop talking about her oral condition and herself and her pain. She's very pain focused. And I was able to, in my diagnosis, your teeth don't need root canals yet. She was convinced she needed root canals. And honestly, the management of this lady was extremely tough. And I was just wondering, from your perspective, because there's something psychologically there. because she could not stop talking. Like, I was actually in the end of the operation. I now have to see the next patient. I have to go. Well, another thing, and like just throwing me symptom after symptom after symptom. And yes, she was a lonely older lady, you know, and looking after her mom and all that. And I was just like, oh my goodness, like, if my prejudice of oral pain, that would be, you know, why someone would not go into oral pain, because it's like, I can't talk anymore. Now, I'm not saying she hasn't got what she's got, but I certainly sticking a file in her tooth is not going to solve it.
Right.
And I this before I knew you were in Calgary. Otherwise, I would have sent you your way. Not because I was dumping, but because I'm just like, you know what, I beyond the PDL, I get a little dumb pretty quick. So specifically in regards to someone like that, who's, you don't want to write them off, and, you know, medicine sometimes their parameter is, well, you're alive, and that's okay, you know. And then dentistry is like, well, we fix subtle things, and then this person kind of falls in between, that really difficult pain patient.
Yeah. So you just described people who I see pretty much every day. So yeah. It is a bit of a balancing act where we want to be engaged with them, for sure, but sometimes we have to also draw the line. But I also think that's providing great service for somebody, of being able to tell somebody what they don't have. This is not a problem. And I think we minimize that sometimes, where we think, well, I don't know what it is. Well, you know what it isn't. And so the person isn't now getting unnecessary expensive treatment that isn't going to solve the problem. So, and then they get burnt out, and then they get frustrated, and then they bounce around to several clinics, and they're still not having their problem addressed. So again, yes, this is the type of person we see all the time. And I'd love to say I've never been held back. In fact, everyone in my office tells me on a pretty routine basis, fewer words, Tom, fewer words. You've got to wrap it up. But sometimes we just have to listen if we're going to accurately diagnose. And many people, once we get to that diagnosis in our clinic, it might not be the diagnosis the person wants, right? Because they are coming to a dentist, like you say, and they want to have it fixed. I know I need a root canal. Why? Well, that will fix it. I know that I'll get the root canal. I've had them before. They work great. Love them. But yeah, this isn't a root canal problem. Are you sure? And so, you know, sometimes you almost feel like you're getting gaslighted, because you think, well, maybe it is. I don't know. Maybe you start to question yourself. But continuing just to reinforce, this is what I think it is. Great. And if you don't know what it is, because we all come up against walls all the time where I don't know what this is. I can tell you what it isn't. I know what it isn't. But I know a person who might be able to shed some more light on this. So I'm going to give you this person's name, and I think maybe getting their opinion is a good idea. I always find that's a nice way if I'm stuck in one of those conversations where I've come at either a diagnosis or telling somebody what it isn't from several different angles, and it's just kind of pew, pew. Usually I will say, look, this is what I know that you don't have. You may have one of these 2 or 3 different things, but I'm not sure. But I know this person is a real expert in this area, and I'm going to give you their name. And I find that often helps, because, again, we all run into walls, right? We all have our areas of expertise. And sometimes once we run out of answers, then I think it's okay to just let them know, hey, I don't have all of the answers, so I'm going to send a nice report over if that's okay with you. And most people will say, yeah, that's wonderful. I'd happily go and let them know. But I think it is that balance between being sympathetic to what they're going through, but also recognizing I can't sit here with you all day. I have other patients. I have other obligations. So I have to move out. And I think for us as dentists, that's part of the problem when we deal with any kind of a chronic pain issue, is people just want to barf their story out. They got to get it out. And I used to I sometimes still do, but try to coach people. Hey, I'm going to ask you some very specific questions. And, you know, if it's easier if you just answer these very specific questions, nah, they're just going to tell you what they're going to tell you. So I just try to fill in, and I'm typing as they're talking, and I'm trying to fill in these long reports as best I can to keep up. And I'll fill in the blanks with lots of other little questions. You know, when did the pain start? Where is it located? What does it feel like? What's the quality of the pain? Is it bright? Is it sharp? Is it dull? Is it aching? Is it boring? Boring as in like a drill, or does it what's the quality of the pain? How many times a day, a week, a month do you get it? Is it every day? Is every time I have something cold? We start to figure out, is this odontogenic pain? It's not odontogenic pain. If it's not odontogenic pain, is it TMD? Is it musculoskeletal pain? Or is it neuropathic pain? So we have this hierarchy that we go down. And when you get the pain, how long does it last? We'll get referrals for trigeminal neuralgia. This person has trigeminal neuralgia. And as we're going down, they're saying, yeah, it's really sharp. It's intense. It's 10 out of 10, really kills me. How long does it last? Oh, it's there for hours. Hours? Hours. Well, we know trigeminal neuralgia, it has several definitions, and one of them is it will last usually a few seconds to at most maybe 2 minutes. Now there's a typical trigeminal neuralgia where after that spike, you can have kind of this really manageable kind of a 2 or 3 out of 10 baseline pain, but that doesn't derail people's day. So when somebody comes in and says, I have this pain, it's there all the time, not trigeminal neuralgia. So that's why we ask a lot of these questions.
Or a highly motivated person with trigeminal neuralgia, which is what I come across with endo as well. How's your sensitivity to cold? And you have to be clever in how you ask the questions. Because if I ask, is it kind of not bad? Is it a short, sharp shock, or does it linger? And just the way I've asked those questions, I know the money answer is it lingers.
Yeah.
So I sometimes go, is it a short, sharp shock? Is it vague?
Yeah.
Does it linger, or does it knock you out of your seat? And you kind of mix, because then they're like, oh, I don't know which is the money answer, because they're so motivated for treatment. They're so and it's like, okay, I understand you're going to get treatment, but it's okay if you answer no to this.
Yes. Yeah. Oh, that's the thing. Like, it's okay to, you want to do the right thing on the right tooth. Yeah. So yeah, we're going to put cold on your teeth, and you may or may not feel that. And that's okay, right? It's okay if you do. It's okay if you don't.
That's why one of the most useful things, and you think it's useless, is to put cold on a root canal treated tooth.
Yes.
They have that patient and they respond.
Like, okay. Oh, it kills me.
Yeah.
Yeah.
Okay. And you don't say, shame on you.
Yeah.
But it's like, okay, that's actually very useful. They're so motivated for treatment. The pain is so anxiety causing. Yes, everything's bad. Everything's bad. And you got to get past that. Yes, I get everything's bad, but and when they delay too in the pulp testing, I'm like, no. If you have to think about it, it's not bad.
Right. Yeah.
It's yes or no, and then lingering. I had a person like, oh yeah, it's still lingering. It's still there. They're kind of like, and I'm like, no. This is like brain freeze, the worst you've ever had, where it's like, don't do that again. That one test is enough. Thank you very much. That's lingering. Oh, okay. Because they're highly motivated, and I can see so many dentists falling into that pitfall, that trap, and I've fallen into it too. I've had a patient come in. I said, oh yeah, irreversible pulpitis, and for whatever reason, I don't see him for 3-4 months. They come back, and you're like, it's not a reversible pulpitis. You're doing okay.
Yeah.
So I get caught. Happens to me, and that's all that I do every day.
Yeah, I think it happens to anybody, and I think any of us who starts to become too confident in our skills, I think a great deal of humility goes a very long way in a profession like this, because people will come in and they will tell you things that you're right. They're motivated for treatment, so they're going to say what they think you want to hear, and going back, repeating. Have you ever had a pulpitis yourself?
No.
I have once. Yeah. And let me tell you, that was one time too many. It's horrible. And having that cold put on my tooth, and I mean, the cold doesn't feel good on any tooth, but once it hit that tooth, is 4-7, holy crap, it had to peel me off the ceiling. It was awful. So, when you have that, it's, you kind of know what's going on. But it's funny, people are very motivated to get that.
And we have to reset our barometers, like after a while, you're like, oh yeah, that hurt that person. You're like, well, hang on a minute. Did it really?
I know. Yeah.
It was damn cold what you put on their tooth.
Exactly right. You almost have to be willing, if you're working with pain, and I think as dentists, we all, at least from time to time, have to deal with pain. You have to be willing to be a bit of a bad guy. You have to be willing to do the thing that you know.
I accept that role full-heartedly.
You do. You just know. I know I'm going to poke this joint, and it's going to hurt. I know it's going to hurt, I
Hmm.
gotta do it. I still have to do it. And so I know we put cold on that tooth, or we percuss it, or I'm gonna poke this muscle, or somebody who has trigeminal neuralgia, and I take a sharp instrument and I start doing cranial nerve testing, and and I know as soon as I get there, I'm gonna poke it, and they're gonna but we still have to do it because
Yes.
it's part of our diagnostic protocol. So thorough diagnostic testing, and back to orofacial pain, and I think it's really critical too when people present with different pain conditions, is making sure that a tooth isn't involved, because the most common orofacial pain is odontogenic, and so making sure you're thorough in testing all the teeth. If somebody says, oh, I have pain back here, blah blah blah, this is where it is, I know. Don't be, and it's easy to slip into this. I guess I'll call it laziness, where you just think, oh, I'll do a little, some perfunctory testing. Don't ignore the teeth. You have to recognize those are part of it, and vice versa. Someone may say, I have this toothache, and it's kind of vague and weird. Start to think, well, maybe this is something else, right? It's not
Yeah.
really clear cut, and maybe something else is going on
Yeah. No, and yeah, absolutely. Those people who've had a root canal on a vital tooth, pain persists.
here.
They end up having either a retreatment or a surgery. Pain persists. They get another tooth root canal treated next door to it. Pain persists. After a while, it's like occlusal adjustments. Stop doing the same thing and expecting different results.
That's right.
Yeah.
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 And that's the funny thing, right? So you see somebody, and we see them here, where every single tooth,
Yes.
upper right, has either been endo-treated or extracted, and they just keep moving, and so, but all the other teeth are fine. So just pause for a minute and think, well, wait a minute, you're having all of these pulpitis, whatever, all your pulp problems are only in the upper right, but everything else is completely fine. That's where I would pause and just think. And you're right, many of these people, and I have been convinced that yes, this tooth is a problem, requires endodontic treatment, and have been wrong, because they're so convincing, and the testing is convincing, and then it gets done, and then it gets retreated, and then there's surgery, and then the tooth gets removed. Don Nixdorf is a orofacial pain specialist in Minnesota. I think he's Canadian. He used to be at the University of Alberta, and he does a lot of research on post-endodontic pain, and he's done some great research on it. And many people who have post-endodontic pain, most recent study did multi-center study, was done 4 places in the U.S. and 1 in Sweden, and there's I think about 700 people enrolled in this study, and they followed people for 6 months. They maintained most of them, and everybody was evaluated by an endodontist and an orofacial pain specialist, pre and post. And so nobody had pain before the endodontic treatment, and they followed people for 6 months, and they wanted to see how many people had persistent pain. And the number was 10%. And some of it was the non-odontogenic toothache or neuropathic pain. Many of them were TMD. I've seen people like this, where it can be very difficult after a root canal. I'll start poking around, and I'll hit a spot, and I'll go, whoa, that's the spot. That's the spot. That's the tooth. And I'll say, that's not the tooth. That's the tendon of your masseter muscle inserting into your cheekbone, but it's right over your tooth. No. Every time I bite it, it kills me. And we'll do it again. And you almost need to get another opinion for them to believe you. And that's okay. I think there's nothing wrong with that. But they finally get the care they need, and their pain goes away. So instead of, again, retreating it and doing surgery and pulling the tooth, and, we're frustrated and pulling our hair out, want to pull their hair out. So that thorough testing, again, being willing to poke around and being confident enough to say, I don't think this is your tooth. But also understanding that if you're going to do root canals, that there are going to be a certain percentage of people who will have persistent pain. The good news is most of them, it doesn't derail their life. They'll report, my activities of daily living are really not significantly affected, but I do have some days where my pain is 7 or higher, which is severe pain. So it's something we certainly need to be aware of and have that conversation before. And two great predictors he found of this persistent pain. One, of course, we know is pain before the procedure, right? You know, the best predictor of post-endodontic pain is pre-endodontic pain. But the other one, which was surprising to him, was the person's confidence that the treatment would work. So people who were very confident that root canal would work had a far statistically significant lower incidence of post-endodontic pain. But people who went into it were like, I don't know, I guess I'll do it. I don't know if this will work. Are you sure this is going to work? I don't know. My Aunt Myrtle had a root canal. It didn't work very well. And I saw that Netflix special, and I don't know. I don't know about this. That group of people also had persistent endodontic pain, post-endodontic pain. So those are the two big predictors. And many of us were surprised by that latter one. I mean, maybe in retrospect, we shouldn't have been surprised, but it surprised me.
Well, and that it had staying power. Yeah, like
Yeah.
you would expect, okay, those naysayers, but then after a while,
yeah,
the dust settles and they're okay with it. But I guess it can linger, and it was found to be there.
Yeah. And that was the surprising one. So I think, and again, so thorough testing, right? So do we want to make sure? So yeah, I mean, people can have a root canal failure that perhaps a canal got missed, or there's an accessory canal or something funky, anatomically speaking. But let's make sure that if somebody's having a retreatment or whatever, that it's being done for the right reason. And so I think we see an awful lot of people who have pain following endodontics or extraction or implant, who end up having persistent pain. So they can be managed, many of them, which is why I think having those heart-to-heart conversations, why we do have informed consent about, overwhelmingly, this is a very successful procedure. Most people have it. It works fine, whether it's an implant or whatever. People have success. They carry on with their life. Everything's pretty good. But there's a small percentage of people who have an adverse response. They have persistent pain or swelling or whatever the problem is.
Yes. Now, how about post-op pain? Do you have a specific regimen that you like to do? Because I know you're keen on doing root canals, and with your pain experience, I mean, the endo world has its rules and regulations, but I'm wondering about the Tom Shackleton post-op instructions.
So one of my favorite things to do is if I can decrease their pain before we do any treatment, I'm super huge on that.
Yeah.
But definitely afterwards. And I have a lot of people who push back on this. We live in a world where a lot of people, they don't really want to take medication, but I really push them to, especially for the first couple days afterwards, just take it around the clock. Take it, especially alternating Advil, Tylenol, or ibuprofen, acetaminophen, alternate every 3 hours. Taking at least 650 milligrams of acetaminophen. We say probably 400 to 600 milligrams of ibuprofen. If you need something more, please let me know, but just take it. And so many people, we contact them and they say, I didn't really have any pain. And, I took those drugs because you told me to, and I quit taking them after a day or two. I mean, this is just the gospel according to Tom, but I also think, well, yeah, you didn't have pain because you took the drugs. Because
you're following the regimen.
Yes, I think it's really critical to, if we can manage their pain before we see them, great. If we can't and we have to dive in and do whatever we have to do, fine. But I want to make sure post-operatively they have it in writing, so we go over it verbally. It's in writing, my cell number's on there, and that they're taking their medication at least 24 to 48 hours. And I say at that point, if you have zero pain, taper down, and that's fine. And this is how you can taper down.
Oh, perfect. So yeah, you get them to do the regimen between acetaminophen and ibuprofen. Yeah. Now, what interests me is pre-op. So pre-op medication. Let's do two scenarios. One, you've done the diagnosis, so you know the treatment is a root canal.
Okay.
That's pretty straightforward. What would you recommend?
It depends. In my practice, I don't prescribe a lot of antibiotics, which is probably weird for a dentist to say. I don't. So if somebody comes in and they're relatively fine, even if it is an abscess, great. let's do treatment. I mean, really, the analogy I like to use is, but I want to manage their pain. So typically somebody like that, I'll tell them before we start, hey, let's start managing your pain. Again, I like the ibuprofen and acetaminophen. If it's a bit more severe, we'll take the ibuprofen out and maybe use something like Torlac. I think that's wonderful stuff. Maybe we'll mix in some Tramacet or Tylenol 3 if they're having quite a bit of pain, and maybe we can't see them until the following day or something. But it's not very common that I'll throw them on antibiotics. My favorite pulpitis pre-op medication is dexamethasone. I love that stuff. So I'm very cautious when I prescribe anything like a steroid.
Yeah.
We want to make sure that there's going to be no complication with medications, no drug interactions, that I'm not, if they're diabetic or they have glaucoma or any metabolic disorder, we want to make sure we're not going to disrupt that. So I use Lexicomp on my phone. I think anyone who prescribes who doesn't use something like Lexicomp or Hippocrates or any of these drug apps I wouldn't do it. I wouldn't feel comfortable doing that at this point in my life. There are just so many medications and so many potential interactions that, so I'll run a drug analysis on anybody who's taking medication when I prescribe something. I just want to make sure that they're aware of any potential interaction, that I can let them know. So let's say there's no interaction, they're fine. So I love steroid anti-inflammatory drug. I'll get them to start that probably a couple of days before we start. Dexamethasone, I'll use 2 milligrams twice a day. And we'll do that for 3, maybe 4 days. So I have them take it breakfast and supper. We let them know that most people don't get too jittery because it's a super low dose. A small percentage can get a little bit of stomach upset. Or if they take it too late at night, you might have difficulty sleeping because thoughts will race through your head and you'll feel kind of squirrely. But short of that, again, super low dose, very short term. And most people will come in, especially with pulpitis, and they'll say, are you sure I need a root canal? Because the pain has virtually disappeared. And so I will usually say, well, now this is where my program director and I part ways. He would say, don't do the root canal, but he's an orofacial pain specialist and doesn't do endodontics. And I said, yeah, we can, but he'll call me back in a week. As soon as he goes off the steroids, it's going to come back. I mean, the decay is not going anywhere. The restoration they had that's deep is still deep. It's still, the pulp's been insulted. So, we have to provide treatment. But I find, and again, I hate anecdotal evidence, but, if we get the pain calmed down, anesthetic is easier. They're more comfortable. I'm more comfortable. They're more comfortable post-operatively. So those are little cocktails I like.
And if you didn't have a diagnosis and they said it hurts and it lingers the cold, would you prescribe medications before you did the exam, or could you see that as a complicating factor?
Yeah, I don't like to prescribe before an exam because that kind of screws up my tests. So if I don't have a diagnosis, like if somebody phones me and if it's a second and they say, I'm having so much pain, I don't know what to do, whatever the pain is, I'll meet them at my office if I have to. I don't want them to suffer. I don't want them to be hung up. It kills me because Canadians are so damn polite most of the time. And
when the Canucks are playing the Flames.
That's always a good time. I was in downtown Vancouver when that city just about got burned down. We were there for a weekend and we thought, what's with the rioting down the street? That was fun. That was a good time.
Yeah.
So, but people, you come into work on Monday and you have that person who says, this started Friday night, but I didn't want to bother you on the weekend. I think, phone me. So if I have to come in, no, I would rather they not take anything before they come in to see me, whether it's whether they're having a odontogenic pain or not a odontogenic pain, because it kills me whenever I start palpating or poking around and I'll say, does that bother you? Well, no, but I just took I took a T3 and 800 milligrams of ibuprofen about an hour and a half ago. Well, I'll see you tomorrow.
Yeah.
Because I feel like my test responses aren't really going to be accurate.
Yes.
What are your thoughts? when
Yeah, I'm pretty much on the same boat as yourself. The difference with me too is the benefit I have is I don't have a medical history, so I'm a little less inclined to have a history with a patient. So I'm like, look, I don't know you from Adam. I really, unless it's excruciatingly bad, I'll see you when I can see you, right? But I do have those patients come in and I just took an ibuprofen or I just took a Tylenol like before you saw me, like you took one and it was not extra strength or anything like that. And you're like, yeah, you know what, you're probably gonna be fine because they're so apologetic and they took so little. It's like I think my results are still gonna be pretty good.
yeah,
Yeah. So as a rule, I tend to find people beat themselves up that they took something beforehand,
yeah,
and it's usually not that big of a factor.
yeah,
But yes, I agree. It's not great to prescribe too much beforehand because it can fog it a little bit. And I've had those cases where patients refer to me and they had an infection and they get a antibiotic prescribed, and then the swelling's gone and they're feeling fine. And you're like, okay, and they're the calcified, every tooth's heavily restored. You can't get an EPT on it. You can't get a responding cold to anything. Okay, which one was it now? Like that doesn't happen that often, but occasionally you're like, wow, I wonder what this looked like when it was raw. But
yeah.
for the most part, I don't think that's a huge thing that dentistry is getting wrong pre-op meds. But it's interesting, and I find the public sometimes beat themselves up a little bit more about it than we do.
Yeah, that's true.
Yeah.
So, again, I prefer they come in with their pain
Raw,
heightened,
yeah,
but you know what? Yeah, if somebody took a Tylenol in the parking lot, nah, I don't
yeah,
care.
yeah.
Okay. So, it's funny because we do see in our practice. I mean, the most common orofacial pain that we do see outside of donogenic pain is TMD, and that's temporomandibular disorders. So we see
Mhm.
people with a lot of muscle pain, joint pain, uh, often a combination of the two. And yeah, that will have. I'm a clencher and a grinder, and so my teeth will occasionally hurt when I wake up, or if I've had a stressful day, I realize that kind of hurts when I bite on it. A day goes by and it goes away. I know that, but so I just avoid it. But we do see quite a few of these patients, and it can be a bit of a mixed bag in terms of what we see. Many pain conditions we only see in older populations, but things like TMD we see the whole range. We see more muscle pain in younger people, more joint pain in older people, which makes sense. But we still see a pretty good number of younger people with having a lot of muscle and joint pain. The funny thing about TMD is it can be a bit controversial. As dentists, we live in a occlusion, tooth-centered universe, and so we want to be able to fix it. And we think if anybody has a TMD, it must be related to an incorrect bite. And so we go ahead and do orthodontic treatment, and their pain doesn't improve. And then we selectively grind all their teeth, and their pain doesn't improve. And then we, do lots of other things, and their pain doesn't improve. Or maybe it does this, it gets better, gets worse, gets better, gets worse, but it doesn't really have any specific lasting effect because, again, we're kind of thinking like dentists. And we know that there are many non-invasive, non-irreversible treatments. In fact, pretty much every dental association in the Western Hemisphere at this point has said, if somebody has TMD, your first, second, or third line of treatment shouldn't be changing their occlusion. There are other things we can do. Medical management, physiotherapy, office-based physiotherapy, things like trigger point injections or joint injections, or again, different medications, appliances where indicated. So, we see these folks a lot, and we can really get a lot of them actually have a significant pain reduction. We're looking for pain-free days. If they have a painful day, we want their pain to not be as severe as it was. So there are a great number of things we can do that are actually relatively inexpensive and easy for people to do. So TMD kind of stresses a lot of people out because we're not really sure what to do. Because we do know that a lot of them come with some anxiety or stress or depression issues. That's okay. We all have stuff. Some people have kidney disease. Some people have a psychiatric issue. That's okay. It's just, we deal with it as we deal with it. And if we're not sure of really what we should be doing, again, that's where we seek help. One of my favorite people at the University of Southern California was this kindly old dentist who practiced in Pasadena named Jack Broussard. And Jack originally is from Louisiana, so he's this kindly old guy, kind of winks at you when he talks. And he has a slow, very even pace. And he said, I always want to make my patients feel comfortable. But he said, one of the greatest things you can do is if you're not sure, refer. Because just his line was, share the risk and share the wealth. Rely on people around you. And if you're not sure, let somebody else help you out. Share the risk. And as we work together and we have that collegiality, everybody's better off. So
Yes.
I think when we see people and they have these pain conditions, even if you know, this is a TMD problem, maybe there's a joint pathology there, and I'm not sure that I really want to do anything with that. Send it off to somebody who's comfortable doing that. And just like, someone looks at a tooth and says, I don't know what it is. Fransen can do that. I'm not touching that thing. And patient's happy, you're happy, everybody's good, right? We're rowing in the same direction. So I think that sense of collegiality, getting along with our neighbors, playing nicely in the sandbox, I think is critical to clinical happiness and success.
Yes. Yes. You can't solve all the problems for all the patients. You'll soon find out that you've now got new problems that other people are there to solve with you.
You create big problems, absolutely.
And you start writing a lot of letters about why you didn't do this and why you didn't do that. Now, what are some hallmarks of TMD?
Sure. So people will often come in and they'll complain of pain on eating. When I chew, especially if it's something hard or chewy, that really hurts. I hear that all the time. So anything hard or chewy, bubble gum, licorice, stuff like that. Hard chewy food is a big no-no. Opening wide can be very painful too. Some people say, man, when I open wide, it kills me. It's like somebody's just ripping my muscles apart. Dull aching pain, often a headache, which is bilateral. It's like a tension type headache. So it's bilateral, it's tight. They'll often say, it feels like I'm wearing a tight hat on my head. My head is just being squished. It's not exquisite. It doesn't tend to make them vomit or have nausea or light sensitivity or sound sensitivity, hallmark characteristics of a migraine, but they'll notice they get this headache. It's frequent. It's there for a few hours. The intensity isn't bad. It's about maybe a 4 or 5. I don't like it. I can still work. If I walk up a flight of stairs, it doesn't make me feel sick. But often they'll get this accompanying headache. And, they'll get to a point where they say, and if it continues, they'll get to a point where they say, I don't really want to go out anymore. Because what do? I talk and I laugh. I talk and laugh, my jaw just gets sore and it hurts, it's tired. And when I'm with friends, we also go for dinner and, we're eating and it just hurts. So you start to see, again, with people who've been suffering TMD for a long period of time, where the global effects of pain start to affect them, where it starts to affect their relationships, it starts to affect how they feel about themselves and things like that. So difficulty speaking, hard, chewy foods, yawning, that's a big one. So many people will see, so those are kind of classic ones. Many people will see with TMD, and it's technically a disorder, but it'll be asymptomatic. They'll have that clicking joint, right? They open it, pop, and you hear their joint just like, and whoa, it kind of shakes you out of your seat. And we still see those people because we want to educate them, because it's a disc displacement with reduction in many cases, where the disc in the joint has slipped ahead of the lower jaw, and then you open, and while it captures it, that's that click or pop you hear. But we want to let them know, hey, kind of back off the number of clicks per day. Try not to, it's a fun party trick for young guys, but try to minimize that, because it can advance to something called a non-reducing disc displacement, or disc displacement without reduction. And that's the person who will call us. That's the person who calls us on a Saturday, where they're having this blinding pain. And you'll see 3 things. They'll say, my jaw used to click. It doesn't click anymore. That's because it's not snapping back into place. And the ligaments in the joint have stretched so far that now they're having severe pain, moderate to severe anyway. But in the early stages, it's severe. They'll say, it used to click, it never hurt, but now it doesn't click. It's killing me, and I can only open halfway. That's number 3. And so they can, they come in, and most people can, but they come in and they're, maybe 1 or 2 fingers, and that's it. So So that's something you definitely want to see. You want to see addressed quickly, and you want to deal with right away, because the sooner we deal with it, the greater their prognosis long term.
Mm-hmm.
Another one that we'll see is dentists, and not to say we're part of the problem, but we're sometimes part of the problem, where we're doing a lower block, and instead of dropping our local anesthetic by the nerve where we should, we drop it into the muscle. And that's the person who shows up the next day, can open about that wide, and they're having lots of pain. So local anesthetic and epinephrine in the dosages we use is very toxic to muscles. So this person you'll drop a carpule of anesthetic right into their muscle. It becomes very, very painful as soon as the anesthetic wears off, and over the next 24 to 48 hours becomes a pretty debilitating condition. Trismus is what we call it, so it's limited opening with pain. And so that's somebody who we want to see right away. We want to get them some pain medication. Non-steroid anti-inflammatory drugs are great. Sometimes you're going to have to mix in an opioid. Not often, but sometimes. Heat, stretching, sometimes muscle relaxants. One of my favorite medications for muscle relaxing is diazepam, believe it or not, because these people are really stressed out. And so we'll give them 5 to 10 milligrams, take it at night just before you go to bed, and do that for about 5 to 10 days. They're stressed out, they're not sleeping, and they're in pain. Diazepam actually does have some nice muscle relaxing properties. So I like it, and it's pretty user-friendly. A common one people like is cyclobenzaprine, which is a good medication. But most people feel pretty hungover the next day. They'll wake up and they'll say, I can't function until about 1 or 2 in the afternoon the next day. Baclofen is also a very nice muscle relaxant. So, if you know that you did a procedure where you did a lower block, and that person comes in and says, oh my God, I can't open, this is what happened, what'd you do to me? This is no fault of a dentist. I've done it. I think if you do enough lower blocks, at some point, it's going to happen to you, and that's okay. Just if you're not comfortable helping that person, again, share the wealth, share the risk, share the wealth. So
excellent. Yeah, no, that's super fantastic. We've covered a lot of good ground. Before we go, another thing.
Yeah.
Night guards. I don't know a lot about them.
Yeah.
But they're everywhere now.
Yeah.
And I almost feel bad mentioning a night guard, because to me a night guard almost seems like just a garbage can. Like, just get a night guard. Yeah. And I'm endo, I don't deal with that stuff. And then patients ask me, well, what about night guards? I'm like, oh yeah, over there. Are they being overused? Is there it seems to be a catch-all. Oh, you're a night guard person.
Yeah, and they'll bring in, hey, you're gonna do an endo. Here's my night guard. Adjust it to make sure it still fits afterwards. Yeah. So night guards still have a place in dentistry. There's lots of different appliances out there. There's so many different appliances. So for people who have any kind of TMD and we're going to make an appliance, the best thing to make in most cases is what's called a stabilization appliance. It can be upper or lower. If you're worried about some sort of sleep disorder breathing, there is some evidence to show that a lower one is a little bit better than an upper one. But it should be flat plane. It should cover all the teeth. You don't have to have any kind of anterior guidance on it. And it can be either hard acrylic, or some people like that dual flex material, because it's a little bit more user-friendly and people wake up without having toothaches, because hard acrylic can be very painful on your teeth. As time's going on and the more research that's being done with these appliances, we're discovering a few things. They're not as great as we once thought. Many people wear them and find little to no benefit. I can tell you, again, think of your standard distribution curve. On one end, we have people love them, they wear them, it's cured everything. That's exceptionally rare. Some people on the other end will say, this hasn't done anything for me. In fact, it's made my job worse. That. Yeah. People in the middle. What we do know, again, flat plane, wear it at night. You don't need anterior guidance. If anyone says you should wear this appliance all the time, that's changing somebody's bite, and that's practicing below the standard of care, because there's no good evidence to support that kind of an approach with an appliance. So the more evidence we're getting, we still use them. I still make them, but I'm much more selective about who I'll make them for. Many people we see who have arthralgias or myalgias, we don't make an appliance for them. We give them some home care exercises, some medication, maybe some trigger point injections or something, some home care protocols, and they do great. So we're using them less frequently because the literature is certainly starting to show us that they're not as great as we once thought they were. And yeah, a lot of people say, oh, you have jaw pain. Well, they throw an appliance at you, right? Because why? It makes us feel like we're doing something. And if you say to somebody, hey, well, stop chewing gum, try to stop clenching your teeth during the day, try to not make your joint click so much, and put heat and ice on your jaw a few times a day. A lot of people don't like that, right? They want to fix. They want it to be made better. And so they don't like a homework assignment. I once saw this young lady. She was 17. She was a senior in high school. She was kind of stressed out, and her left joint was killing her. I couldn't go near it. It was to touch it. She just jumped out of the chair, and her parents were very concerned. And so we talked a little bit about her life. And this is important, why it's important to talk about people's lives too. Because, well, what's your situation? Oh, I'm a high school student. You want to go to university next year? Yeah. I'm working really hard. How's it going? Well, it's really challenging, really competitive. I want to go into engineering. That's a difficult program. So I've got to get really good grades. I said, you finding school stressful? Yeah, it's really stressful. How's home life? Our parents are sitting right there. Home life is fine, but I have to, I have chores and I have to do homework, and, job. And so I said to her, so we do our exam, and at the end I said, I think you're clenching your teeth a lot. And she's like, stupid, I'm not clenching my teeth. And I said, maybe you are, maybe you aren't. I said, how about this? Do all these other things, stretch, ice your jaw. We're going to give you, take this anti-inflammatory medication a couple times a day, super low dose. I'm going to see you in 2 weeks. But also set a timer on your phone for every 30 minutes. And when you're sitting in school and your phone goes, just ask yourself, am I clenching? And if you are, go to a neutral position where your tongue's on the roof of your mouth, your teeth are apart, just by a couple millimeters, and your lips are together. And just do that, and we'll see you in a couple weeks. She came back in 2 weeks, and she said, I had no idea I clenched so much. I clench all the time. I'm sitting in class, I'm clenching. My teacher asks me a question, I'm clenching. I'm doing the dishes, I'm clenching. And I said, so how are you doing now? She says, I'm way better. I still clench, but I'm way better. I said, how's your jaw? She said, zero pain. I feel great. So this was somebody who, could have had an appliance and medication and blah, 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 and joint injections and stuff and orthodontic treatment. And I just think, just saying your life is stressful. I get it. Let's maybe declutter some of that and do these things, and you'll find you're better. One more example, sorry to keep you, but this other lady we saw, we're talking about, she's having all this pain. She was an engineer. And I said, so, are you married, single, or divorced? She goes, well, I'm engaged. And I said, okay, do you live with your fiance and people think, oh, these are invasive questions, but there's a reason for them. And I said, wait, are you living with your fiance, or do you live apart, or what's happening there? She goes, well, he moved in about a month ago. And just the way she said it, I said, well, how's that going? And she's like, well, I love him, but I mean, it's hard. Like, it's been really hard. It's been challenging. Like, there's a lot of friction. We're trying to plan our wedding. I said, okay. I said, so what do you do for work? I'm an engineer. I said, so are you like a P-Eng, or what do you do? She goes, well, I'm a chemical engineer. I'm going through the process of becoming a professional engineer. I said, how's that? Ton of work. Good? Like, are you enjoying it? She goes, yeah, but it's a lot of work. I said, okay. I said, so anything else? Well, my sister's getting married. I said, well, that's exciting. And she goes, yeah, I'm the maid of honor. And like, it's, I'm supposed to plan this getaway girls trip, bridal party thing. And how's that going in the midst of the boyfriend and the PNG? She goes, it's driving me crazy. And then she just stopped for a minute and she goes, this is why I have all the pain, isn't it? And I said, it could be. I mean, it's sure not helping you, that's for sure. So we saw her a couple of times, and she got through all that stuff, and her pain went away. Well, I love the biopsychosocial model of pain. Here's why. You'll see somebody who has horrible pain. Everything we're doing really isn't working that well. It's okay, but it's not great.
Yeah.
And they'll come and see me for a follow-up. How are you doing? I just spent 3 weeks in Mexico, and I was pain-free the whole time. So if this was an occlusal problem, it doesn't matter where on the planet you are, it's an occlusal problem. I see this again and again and again and again and again. And people come back and they'll say, I feel great. And they go back to work. Or, the person at their workplace. Classic is a school teacher. Well, the teacher down the hall transferred, my pain went away. My vice principal is no longer at the school. My pain went away. I went to a different school. My pain went away. I see this all day, every day. So I sometimes wonder when I hear about people's situations, and I think, am I helping them? I don't know. Maybe not. Maybe I don't know what I'm doing, but I hope I'm part of the solution, not part of the problem.
Yeah.
But again, Dr. Clark used to always say, you can't take people out of a crappy commute, a crappy job, or a crappy marriage. What we can do is give them tools to help them, manage whatever their situation is. So, and not to say there isn't a biological component to these. There are biological components.
That's a natural prejudice, is the biological, right?
Yeah, I just don't think it's as simple as grinding a few teeth in there or throwing a splint at them and their pain's going to go away. So,
yeah, and so a splint should not be worn all the time.
Definitely no, absolutely 8 hours a day maximum, and you choose the 8 hours, but usually at night because it's going to protect your teeth. Now, splint will protect your teeth from the effects of grinding, right? I'm a bruxer. I've worn my teeth pretty flat, so I'll wear an appliance because I know that it will protect my teeth. There is some evidence to suggest that it does offload a tiny bit of pressure from the jaw joints. So if somebody's having a joint problem and I can't manage it any other way, many times then I'll rely on an appliance to help out. I can tell you that, they're okay. I've seen people who wear them 24 hours, but the problem is now we've induced a severe malocclusion. So because now they can't close, once you take the appliance out, they have a posterior open bite. And so what are we going to do now? Well, I guess we can do orthodontics. And I've noticed that people who tend to live in that occlusion-centered correction universe have moved more towards doing orthodontics as opposed to, doing 28 crowns on somebody's teeth, doing a full rehabilitation, which, in my opinion, is horrible. It's, they're going to need, especially when it's done on somebody who's in their 30s, it's not going to last forever, maybe 10 years. They're going to need units replaced. They're going to lose teeth, endodontic treatment on probably multiple teeth. And, so the initial outlay of whatever it is, $50,000, $60,000, $40,000, I've heard higher. That's round one, right? What's it going to be in 10 years when you have to do it again?
Yeah.
And then in 25 years when you have to do it again.
Yeah.
It breaks my heart when I see that.
Yeah.
So I think 8 hours a day, let's not introduce any bite changes. And the nice thing I will say about an appliance, if you're only wearing it 8 hours a day, if somebody finds that either it doesn't work or it's working, but they can't tolerate it, they find it hard to sleep, they just simply take it out and, okay, let's move on to something else. So we try not to have that kind of a failure with an appliance, which is why I try to be a bit more selective about who I'll make an appliance for and who I won't. I try to actually not make them unless I find, we're really struggling here. But some people absolutely love it. They do well. They say, I can't sleep without it. Awesome. Perfect. If I see somebody who's bruxing really hard and they're 30 years old, I'll tell them, look, you probably will benefit from this if for no other reason it's going to preserve your teeth. So let's do at least that. It might not get you out of pain, but at least your teeth will be preserved. So I think that's a nice service to provide.
Yes, no, definitely. That's excellent. And every night? Or are there some cases where you say, no, 3 nights, 1 night off, 3 nights, 1 night off? Or is that
with somebody? If somebody's bruxing, I want them to wear it every night.
Mm-hmm.
But again, we're not big on guilt around here. So if somebody comes in and will say, how are you doing with the appliance? It's fine, feels good, fit, everything's good. How many days a week are you wearing it? They kind of shrug and they're like, 4. And I'll say, that's fine. Don't beat yourself up. If you're wearing it 4, that's better than none. That's 4 nights where you're not wearing your enamel.
Yeah.
So it's okay. That's, I'm not going to beat anybody up over that.
What about the stress-induced person who perhaps, is that just a dual nation, or does that actually exist where the person, like, normally they don't, not on under a lot of stress, they're fine, but up for a holiday or something bad, they're grinding at night.
Yeah, and some people are like that. So some people will tell, but we always let people know if you take too much time off your appliance, it's probably not going to fit really well. So try not to take too much time. But yes, stress has a very huge direct relationship with pain. And so and some people will tell us, and I am finding stress at work. Yeah, that post vacation time, my appliance is my best friend, because I know I'm just grinding and I'm wearing my teeth, and I have fewer toothaches when I wake up in the morning. So around those stressful periods in life, my daughter's getting married, or my father's sick, or something like that. People will wear that because they do tend to grind those teeth a little bit more when they're stressed out. Interestingly,
yes,
bruxism alone. So we often have thought that if somebody's a bruxer, they're going to have jaw pain. Absolutely. Recent evidence, probably in the last 5-10 years, has shown that bruxism alone, most people won't have jaw pain. They'll come in, they're wearing their teeth flat. I'm a good example of that. I will clench. Actually, daytime clenching has a much greater indirect relationship with pain than nighttime bruxing. So when we brux, we tend to do it as we're going from a deeper level of sleep to a lighter level of sleep, and we tend to do it in maybe 2 to 3 second bursts. We kind of go, and that's it. And so it's more like actually going to the gym. There are some studies that show that actually has a protective effect on pain. And many people who brux not only don't have pain, they can. Now, if somebody's severe and maybe there's other life things that come involved, sure, but bruxism alone doesn't really seem to cause a lot of pain. Daytime clenching becomes dysfunctional because we're doing it for hours on end. So the example I'll use with people is if I put a 10-pound weight in your hand and said, now hold your arm at 90 degrees and don't let it drop. After a while, your muscle is not only going to fatigue, but it's going to start to hurt. And so when we're doing that with our jaw, it'll just keep going, because these guys, unlike our bicep, are postural muscles. They're fatigue resistant. Otherwise, by 3 p.m, we'd all be walking around with our mouths gaping open. So they'll keep firing, and then they become anaerobic. And so we're overworking them, and that can become pretty painful. But bruxism alone, just that sleeper, bruxism alone doesn't tend to cause a lot of jaw pain, unless it's an extremely severe case.
Botox and masseters, crazy?
We will do that now and again.
Yeah.
Only if, I don't think it's crazy. I think it's overdone. I think it's overused. I think it's oversold. I think it's overhyped. We will do that after everything fails. So we've tried everything.
Yeah.
And, we've tried amitriptyline. No, either they can't take it or won't take it, or they'll tell us it doesn't have an effect. Whenever that happens with me, I'm like, are you sure? Because this is a pretty good, anyway. So that doesn't work. Trigger point injections don't work. I love trigger point injections. A little bit of lidocaine, feel some of these ropey bands in some people, and they'll go, that hurts. It reproduces their pain. It may refer. It's a miserable condition. Stick a needle right into that top band, which doesn't feel great. If you've ever been to physio and they've had dry needling, you'll feel the muscle twitch or spasm. And so trigger points will do that. Again, Botox, if we've tried everything and it doesn't work, we'll put some Botox in here. We'll do Botox in here, maybe up here. And we get pretty good results with it, but we don't want to do it forever. And I tell people, we may do it a few times. Sometimes we'll do it a little bit more. Those are exceptional cases. So the only people we tend to do it in more frequently. So I categorize my jaw pain, the TMD people, in 2 big categories. One category is those who've been traumatized, and typically motor vehicle accidents, and those who haven't. So those who haven't, it's very rare that I'll do Botox in these people. Like one time I can think of, one person. But she has a lot of stress and anxiety in her life. She's a lovely person, but just there's a lot of other issues there. This group, especially motor vehicle accidents, and we know from the literature, they don't tend to respond really well to treatment. And so I tend to do it more in this group. A small percentage of the time we'll do it, but again, only after we've exhausted everything, without effect.
Yeah. Wow, Fascinating. That's really interesting because my wife had Botox to the chipmunks. It was quite helpful, but this complements what you've been saying because as she went through everything. But this has all been, I very much enjoyed our little conversation.
Hey, me too. This has been fun.
Yeah, and Zoom behaved. I did an interview this morning, and when I came up to half an hour, I got very quiet. I'm like, oh crap, we're gonna get cut off. Right now, it's giving me all the time in the world, which is wonderful. I guess it rates the quality of the answers to my questions. And
That's right. I'm not going to say it has anything to do with the guest, but I'm just saying, maybe.
Zoom likes you.
Well, I'm glad something does, because nobody else seems to.
Well, Tom, it's been an absolute pleasure. Yeah, and I'll post this up on PFX. Some people have some questions. Because I've interviewed you, you'll have access to PFX. PureFX it's an online site for CE,
right.
and dentists pay an annual fee to be on it. And it's getting off, honestly, it's getting some momentum. And this is absolutely super fantastic. This has been
my
wonderful.
pleasure. Yeah.
Yeah, no, thank you so much. Yeah, so I will going to end the interview now, but I'm going to stay on the chat. So thank you so much, Tom.
Yeah, my pleasure. Thanks.
Yeah, and we'll definitely chat again.
You got it. Have a great day.
You too.